Trauma. So what we're going to do is we're going to identify the anatomy, physiology, epidemiology, pathophysiology, psychological impact, presentation, prognosis, and management of pulmonary contusions, blunt cardiac injuries, management of the hemothorax, and management of a pneumothorax. We're also going to learn how to manage a cardiac tamponade. We're also going to manage rib fractures. We're also going to manage flail chest segments and also management of commotio cordis. We're also going to learn how to manage tracheal bronchial disruptions and also manage a traumatic asphyxia. All right, so thoracic trauma. Trauma is the chest cause both internal. Make sure we're doing good. All right, so trauma to the chest can cause both external and mass internal injuries. It is important for the paramedic to have a functional understanding to the thoracic anatomy, as well as signs and symptoms accompanying trauma in the area so that the patient's condition may be properly managed. So thoracic injuries is the second leading cause of death in a trauma. About 20 to 25% of trauma deaths are caused by chest trauma. Chest trauma is also a contributing factor to 25% of the remaining deaths. It is often associated with blunt chest trauma that affects heart and great vessels. Patients with these injuries will immediately die. Other early deaths from chest injuries are caused by tension pneumothoraxes, cardiac tamponades, flail chests, and pneumothoraxes. So your chest trauma includes rib fractures, flail chests, sternal fractures, lung injuries, myocardial injuries, and tracheal bronchial injuries, esophageal injuries. These are very painful injuries, primarily involved 3 through 8, ribs 3 through 8. Rib fractures 1 to 3 are very serious and usually involves underlying organs and vascular structures. Simple fracture can interfere with the breathing, leading to atelectasis. It can be self-splinted or padded, then slinged and swathed, placed on the patient. Do not tape or strap chest. Encourage patient to deep breathe. Cough may require positive pressure ventilation. All right, so flail chest causes inadequate ventilation and oxygenation because of it's an interruption, the bellows action of the chest wall. The probable underlying chest injury, pulmonary contusion, pneumothoraxes. Patient may exhibit severe distress with hypercapnia, hypoxia, cyanosis, chest pain, and accessory muscle usage. Splitting with padding and sling and swathe patient's arms to the affected side. If positive pressure ventilation is used, apply with caution due to the possibility of a pneumothorax. So here is how a flail chest works. So usually got at least 2 or 3 or more broken ribs that it may or may not be connected to the the fractures of the sternum side may or may not be fractured also. So during inspiration, whenever you're trying to suck the air in, it's going to suck in that section of the chest because of the instability. Now, whenever you're trying to exhale, what happens is it pushes that section outwards, and it causes the chest to just be way too pliable to allow to allow good ventilation. So the loss of so whenever you have a sternal fracture, you have loss of chest integrity. The injury may cause a self-splitting, leading to so aticolysis. Many severity may severely compromise breathing. Watch for hypercapnia, hypoxemia, cyanosis, respiratory failure. Positive pressure ventilation may be necessary. All right, so here's a picture of a sternal fracture. So as you see, the um, the big white thing in the middle of your screen is probably going to be the spine. And with the fracture, you have a huge instability in the center of the chest, more on the left side than the right side, and it's going to cause a huge amount of instability and cause the patient to become ataxic. All right, so simple pneumothorax. So what you want to do is, or sorry, pulmonary injury, simple pneumothorax. So the presence of, this is going to be the presence of air in the thoracic cavity, which cause from a partial or a total collapse of the lung. If the collapse is partial, patients may compensate only by increasing the respiratory rate. If the collapse is total, there will be more profound respiratory distress. The danger is that it may develop into a tension pneumo. A tension pneumothorax is when the air is accumulated in the thoracic cavity and cannot escape, causing air to build up under pressure in the chest cavity. See severe respiratory dysfunction, altered mental status, cyanosis, hypercapnia, hypotension, absent breath sounds, and JVD may occur. Decrease cardiac. It's going to help. It's going to decrease cardiac preload and possible cause subcutaneous emphysema. Tracheal deviation is very late signs. Treatment is the treatment for this is going to be chest decompression, open pneumothoraxes. This is going to be your sucking chest wounds. This is going to be what you want to do is you want to cover open and around the occlusive dressing. Tape on 3 sides may help burp if the wound if the pressure begins to build up as the tension in the pneumothorax begins to develop. The hemothorax. This is going to be just like the pneumo, except it's going to be filled with blood versus air. You could easily do the percussion test to tell the difference between the two. The way you do it is basically listen to lung sounds. You're going to need to notice an absent or diminished lung sounds. Do the percussion test. Just give it a nice little thunk. If it sounds like a melon, more likely you got a hemothorax. If it's high pitched, like what a balloon would sound like when you thunk on it, more likely you're going to have a hemothorax. So, I'm sorry, a pneumothorax. A hemothorax is a difficult to determine. Breath sounds may be missing. Patients may exhibit respiratory distress, hemotysis. If the hemothorax is large, patient will show signs of hemorrhagic shock. Chest percussion will be a dull sound. All right, guys, I'm going to keep on pushing through so we can get on to our lunch break, okay? Thoracic trauma, the myocardial injuries. I don't think we have much. Yeah, we got about 20 more slides of this, and then we're going to break for lunch. All right, so the thoracic trauma, the myocardial injuries and management. So cardiac injuries, usually what we're talking about is we're going to talk about the cardiac tamponade. We're going to talk about the pericardial tamponade. Usually caused by blunt or penetrating trauma. Effects depends on the amount of blood in the pericardial sac. Usually holds between 2 to 50 mLs of pericardial fluid. The accumulation of 150 to 200 mLs of blood can be fatal. If accumulation is slow, the pericardial sac can hold up to 2 liters of blood. So if you see right here, here's a bad cardiac, not cardiac tamponade, a huge amount of fluid built up in the pericardial sac. I've never actually seen it that bad. I've seen some pretty hairy looking ones. I've also seen it where the heart's been overly is overly um, overly incised due to like things like renal failure, patients not taking care of themselves, and so on. So a progressive decrease in you're going to notice is a progressive decrease in diastolic filling pressure, which causes stroke volume and cardiac output to fall, leading to a drop in blood pressure. Patients will show signs of progression, compromise, falling blood pressure, altered mental status, cool, clammy skin. You may also know as Beck's triad, which is going to be a diminished heart sounds. You're going to notice hypotension and narrowing pulse pressures. May also show pulses, paradoxes, which is a fall in diastolic blood pressure by 5 to 10 millimeters upon inhalation. All right, so the definitive treatment for pericardial tamponade is going to be the pericardiosynthesis, which in which a cardiac needle is inserted into the space between the outer wall and the pericardial sac. The heart and blood is withdrawn. I'm sorry, the heart and the blood. So around the heart and the blood is withdrawn. There we go. So as you see right here, they're going to insert a 16-18 gauge needle through the chest into the sac, and they're going to withdraw blood from that sac. So myocardial rupture. So most common causes of myocardial rupture is going to be rupture of the necrotic tissue from the previous acute myocardial infarction. But myocardial rupture can occur from blunt trauma due to rapid deceleration. This is a fatal injury, and the patient is most likely to be dead upon arrival. Very few patients survive this injury. The usual presenting signs and symptoms are cardiac arrest. If not, signs and symptoms of a tamponade may be present. Rapid transport, do not delay. All right, so the comido cordis. So this is a sudden blow to the chest wall near the heart, which causes a cardiac arrest. Line drive, not mechanical damage, and it's not caused by heart disease. This has a 65% fatality rate, even with immediate CPR and defibrillation. The rate of successful resuscitation remains relatively low, but it is improving slowly. Although it usually involves impact with a baseball, it can also have been reported during a hockey, softball, lacrosse, karate, and other sport activities in which a relatively hard impact projectile or body contacts cause impact to the person's pericardium. The patient will most likely be arrested when you arrive. Here's a picture of it. As you see here, looks like the guy takes a punch to the center of the chest, and it's able. That's all it takes. So here's some more useful information about how often it happens. As you see, most of the time it happens from baseballs. Then it can happen from softballs, hockey pucks, lacrosse, all the way down to tennis balls can even cause this. Oh, tennis ball filled with coins. That's a little different. That's just somebody having a bad day right there. All right, so the traumatic asphyxia. This is going to be a severe crushing injury to the chest that forces blood into the veins of the upper chest, neck, face. Traumatic asphyxia is not lethal, but rather the force that caused the injury are, if the patient is not in arrest, manage the ABCs, O2s, and rapid transport. Here's a picture of a traumatic asphyxia. Or other injuries caused by thoracic trauma. So yeah, aortic dissection, tear or traumatic aneurysms. This is where the great vessel injury carries about 100%. It has a 100% fatality rate. About 80-90% of the patients with this injury die immediately. Clinical findings are severe chest pain, pressure, dyspnea if conscious long enough, hypertension in the upper extremities if the patient's periaortic hematoma forms, partial aortic occlusion. This may also be a harsh systolic murmur or auscultation of the heart. Rapid transport, do not delay. All right, the tracheal, bronchial, and other injuries. So we're going to talk about esophageal tears. This is caused by blunt trauma, penetrating trauma, also ingestion of foreign bodies can lead to leaking of gastric contents into the mediastinal space caused by severe sepsis, mediastinitis, and massive fluid loss. Signs and symptoms could be shock, chest pain, dysphagia, heartburn, and subcutaneous emphysema. Most commonly caused by blunt trauma, air escapes from the bronchus into the surrounding areas, presenting as subcutaneous emphysema. The tear may be small, and since the bronchus is rigid, it will maintain its shape. A massive disruption to the patient have some hemoptysis, severe dyspnea, and also subcutaneous emphysema. Appropriate airway management with supplemental O2, you may want to include endotracheal intubation, positive pressure ventilation, CPAP, and also SpO2 and O2. O2 has to maintain between 94 and 95%. UC C-spine precautions, IV, EKG, and you want to do some analgesics en route. Also, may look at doing a chest decompression. All ALS must be done en route with the exception for airway management if needed. Transport patient to a trauma center and consider air evacuations. All right, chest decompressions. So at the end of this completion of this lesson, paramedic professional students should be able to identify the clinical findings in attention pneumothorax, explain the procedures involving performing chest decompressions. The procedure of a chest decompression is important to the procedure to ensure proper ventilation of the patients who is experiencing signs and symptoms of attention pneumothorax. The paramedic must make certain that he or she can identify the needs as well as perform the procedures properly. So the needle thoracotomy. It can be effective and be life-saving intervention in a patient with attention pneumothorax. Indications are the signs and symptoms signs of attention pneumothorax, which is going to be respiratory distress increasing despite adequate care, pain, unequal breath sounds, low blood pressure, poor perfusion, ultravital status, hyperextended chest wall, decreased breath sounds on the opposite side, increased resistance to positive pressure ventilation, slow breathing, may be very, very ominous signs of impending respiratory arrest, pulsus paradoxus, JVD, subcutaneous emphysema, trachea deviation, which is a very late sign. So what you're going to do is you're going to take a large bore chest decompression needle. Standard IV needles aren't long enough. Average chest wall is about 1.8 inches thick for decompression kits. A lot of times services will order the 14 gauge needles with a 3-inch catheter. So sites. So what you want to do sites for insertion is going to be second intercostal space, mid-clavicular line, medial to the nipple line, or the fourth or fifth intercostal space, mid or anterior axillary line. What you're going to do is you want to have a flutter valve where you can, so it can form using a finger from an examination glove. As always, ensure adequate airway, breathing, and circulation with supplemental O2 rapid transport. So as you see right here, here's going to be your illustration about where's the best place to do it. You're aiming for the second intercostal space. So right below the clavicle starts number 1. You're going to find that rib right below there. Sometimes you may have to push a little harder because some people it's easier to find than others. And then you're going to go to the next one. And you're going to do it mid-clavicular.